over attention deficit hyperactivity disorder, ADHD. And presenting, we have Dr. Pratal Desai, Barbara Farrell, and Aubrey Vance-Tovry. And some of the objectives that we're going to be discussing today are explaining the burden of ADHD in the society, evaluating and treating ADHD, differentiating symptoms of ADHD from other psychiatric disorders, demonstrating the ability to manage ADHD patients with co-occurring psychiatric disorders, assessing and managing patients with ADHD in the background of substance use disorders, applying non-pharmacological approaches to treating ADHD, and explaining myths about ADHD surrounding treatment. Okay. And I'm going to go ahead and hand it over to Dr. Desai, and then she'll get started on her section of the course.
Good evening, everyone. I'm Dr. Desai. I'm a psychiatrist working at an outpatient clinic, Siyan Clinic here in Santa Rosa, and I see children, adolescents, and adults 5 years and above in my practice. So I'm going to start with talking about attention deficit hyperactivity disorder in general, starting with some history, features, criteria, diagnosis, assessment, and some of the medication piece. So ADHD is a neurodevelopmental disorder. It remains the most treatable disorder in psychiatry, and it's also the most researched topic in child psychiatry. On this slide, I want to spend a few minutes just to give you a brief introduction on history, timeline of definition of ADHD and diagnosis. So in 1900, George Still described ADHD symptoms for the first time. After that, in 1957, the first diagnosis to describe children with symptoms of ADHD was of hyperkinetic impulse disorder. So that's how the first diagnosis came up. In 1970, DSM-2 was released, and it identified the syndrome as hyperkinetic reaction, based on then prevailing psychodynamic philosophy that mental disorders were always reaction to some stressor. And the hyperkinetic disorder term is still in use by the ICD International Code of Diseases. Next, in 1979, Douglas and Peters' group suggested that attentional deficits rather than hyperactivity are the core symptoms of ADHD. Recognizing that cause of most mental health disorders are more complex rather than just a reaction to stress, in 1980, DSM-3 changed to more descriptive phenomenological terms and termed the diagnosis as attention deficit disorder with or without hyperactivity. After that, in 1987, DSM-3 text revision came out, which included the hyperactivity term back into the name and termed it ADHD, and that's what we all know today. So in 1980, in DSM-3, it was ADD. A lot of people in the society still use the term. A lot of support and advocacy groups such as CHAD, Child and Adult ADD program. So many people still use the term ADD, but officially per DSM-5, it's now ADHD as of 2014. In DSM-4 in 1994, the criteria were also a bit changed from 14 to 18 symptoms, and it was split into two categories of 9 each. In 2014, when DSM-5 came out, the change was made from age requirement cutoff from 7 to age 12, and criteria was still preserved, and the name attention deficit hyperactivity disorder was preserved in the DSM-5. Next, the prevalence, there's 11% prevalence of ADHD in children and approximately 5% in adults. Ratio of male to female in children is 4:1. Ratio of male to female in adults is 2:1 or 1:1. Girls present more often with less disruptive symptoms, more attention symptoms, and more internalizing problems such as depression and anxiety. Boys present with more disruptive behaviors and externalizing problems. And this is the reason why girls may go more undiagnosed for many years and sometimes even for lifetime. Now, next slide. There are three major categories of core ADHD symptoms, which divide into inattention symptoms, hyperactivity symptoms, and impulsive symptoms. Inattention can itself be divided into difficulty with selective attention and difficulty with sustained attention and problem solving. Next, different brain areas are hypothetically important in the symptoms of ADHD. Alterations within, if you see the first part of the extreme left-hand side of the diagram, you will see the alterations within the orbitofrontal cortex are hypothesized to lead to problems with impulsivity and hyperactivity. Inadequate tuning in dorsolateral prefrontal cortex area of the brain can lead to problems with sustained attention and problem solving, and problems in dorsolateral anterior cingulate cortex can lead to problems with selective attention. Therefore, it is becoming clear that dysfunction in specific areas of the brain lead to specific symptoms, such that abnormalities in orbitofrontal cortex, orbitofrontal limbic motivation networks have been observed in children with conduct disorder, while aberrations in the dorsolateral cognitive network have been observed in children with problems of sustained attention. Now, the role of genetics. Genetic factors account for 60% of the heritability, thus being split between environmental and child-specific environmental influences. Twin studies have shown that monozygotic concordance rate is 59 to 92%, pretty high. Dizygotic concordance rate is 29 to 42%, suggesting 75% of variance in the transmission of ADHD is attributable to genetics. Sibling and half-sibling studies also suggested significant genetic influence on transmission of ADHD. Adoption studies showed that biological relatives of children with ADHD are more likely to have ADHD or associated disorders. Family studies showed first-degree relatives of children with ADHD have a 20 to 25% risk of ADHD, compared with 4 to 5% for relatives of controls. And ADHD parents have up to close to 50% of offsprings with ADHD. And lastly, ADHD shares its genetic etiology with other psychiatric disorders such as schizophrenia, depression, bipolar, autism, and Tourette's. Several genes have been identified that are linked to ADHD. I've not listed them here, but there are a number of them which have been linked to ADHD. Next, talking about some brain imaging studies, structural brain abnormalities in ADHD show that smaller brain volumes, especially in dorsolateral, prefrontal, orbitofrontal, and anterocingulate cortex areas of prefrontal cortex. It has also shown smaller caudate volumes, smaller pallidum volumes, smaller volumes of corpus callosum, as well as cerebellum, including vermis. Functional neuroimaging studies of ADHD showed on SPECT studies that hypoperfusion in various critical areas, especially frontal and prefrontal cortex, striatum, and cerebellum. Functional MRI studies have shown decreased cerebral blood flow to frontal, parietal, and basal ganglia, decreased activation of these regions during certain cognitive tasks, and atypical increase in activity in other areas of the brain to possibly compensate for the hypoactivation, and normalization in brain flow, cerebral blood flow in these areas following administration of methylphenidate. And lastly, the PET studies have shown decreased glucose metabolism in prefrontal, frontal, and other cortical areas, and reduced metabolic rate in same areas during cognitive tasks. These few slides support the idea that ADHD is a neurodevelopmental disorder rather than a disruptive disorder, which was what it was recognized as prior to DSM-5. And this also helps and supports in debunking the myth that has been there over the years. Many years ago, ADHD individuals would be just labeled as being lazy, as just disruptive and problematic kids. But now the whole understanding and all the studies and research that has been done in the field has changed how people look at it. EEG electroencephalogram studies have also shown some increased low wave activity in ADHD. It's important to note here that neuroimaging tools are not valid tools for diagnostic purposes. They are not neither sensitive nor specific enough to be used for diagnostic purposes. Now, etiology and risk factors. It's a multifactorial disease. ADHD is a multifactorial disease, so there are several factors that play in. I talked about the genetic factors that account for that contribute significantly to ADHD in an individual. And in addition to that, the environmental and biological factors are pregnancy, delivery complications, prenatal exposure to alcohol and other drugs, cigarette smoking, very low birth weight, complications in pregnancy, perinatal trauma, brain injury, abuse, neglect, heavy metal poisoning. Lead exposure is very important, especially in children, and often guidelines recommend that you consider checking lead levels in the blood test. Exposure to organophosphate herbicides also can play a role in some cases. Male sex, low socioeconomic status, and young age increases the risk for ADHD. Associated features, executive function deficits, which include problems with planning and organization, cognitive flexibility, working memory and response, inhibition or impulse control, are significant deficits seen in ADHD individuals. Impaired working memory. When we talk about working memory, it's the ability to retain information while processing new information. Response inhibition would entail ability to juggle competing or distracting tasks. Also, verbal learning and coding can be a challenge for ADHD individuals. Delaying aversion, that is need to have immediate gratification, where you may see some frustration, especially in children and young kids. Further, this mild delays in language, social, and motor skills are also seen. Social rejection, poor interpersonal skills, low frustration tolerance. Another important piece next to executive function deficits is emotional dysregulation, which is quite prevalent in ADHD. It's manifested as chronic irritability, reactive aggressive outbursts, and severe mood lability, and it affects up to 25 to 50% of ADHD youth. And lastly, a variant that has a sluggish cognitive tempo, which has been talked about in recent years, is described as slow retrieval and information processing, low levels of alertness, and mild problems with memory and orientation. This needs further research. It's not yet known whether it's just a variant of ADHD or it could end up being a independent diagnosis in itself. Next, since in the previous slide I mentioned the executive dysfunction, I want to spend a couple of minutes on this slide just to explain how it may be linked to ADHD. So it's hypothesized that synaptogenesis in the prefrontal cortex might be responsible for altered connections that could prime the brain for ADHD. So if you see in the figure, by a first year of age, working memory starts to emerge. When the child is around 3 to 4 years of age, children do not yet have the capability to sustain attention for long periods and can be easily distracted. By age 6 or 7, this changes, attention can be sustained and planning can take place. This age is characterized by synaptic pruning, a process during which overproduced or weak synapses are weeded out, thus allowing for the child's cognitive intelligence to mature. Errors in this process could hypothetically affect the further development of executive function and be one of the causes of ADHD. But specifically, the executive function emerges around the period of adolescence. Now, although hyperactivity and impulsivity are the key symptoms in childhood, inattention becomes prevalent as the patient ages. And if you look at this diagram, preschooler is normally unable to sustain attention, and then if you see the chart, the arrow, it increases and it may increase as the patient ages, and inattention may persist for rest of the life, or it may some patients may have remission of symptoms at a later age. Then if we look at the impulsivity is high in preschool and school age, and it goes down gradually by the time they reach adolescence. And it may be it may be still there, but it's in a different form, in the form of risky behaviors, legal issues, substance abuse issues, etc. And if you look at the hyperactivity curve, it is high from preschool, school age, and then it starts going down around adolescence, and then it goes below the threshold and hyperactivity limits. And at the same time, if you see the comorbidity, they start being recognized as the patient grows older, and it may increase to about threshold level. And if you see the description of the challenges that each individual faces, you may see academic, behavioral, social interaction challenges, and throughout the span, you may see low self-esteem issues because of failures in different personal and professional life for a patient with ADHD. Now, going to the course, just reiterating few points from the previous slide, more than 70% of children with ADHD continue to experience symptoms in adolescence. Almost 65% will continue to have symptoms as adults. 2/3 of children with ADHD have at least one coexisting condition. Hyperactivity and impulsivity are the first to decline, and inattention is the last to remit. It's important to note that most persistent symptom cluster in adult ADHD is disorganization, inattention, distractibility, and failure to finish things. Now, many individuals go undiagnosed for years for various reasons, and the untreated consequences could be individuals' risk of school failure, unemployment, interpersonal difficulties, other mental health disorders, substance and alcohol abuse, injury, accidents, antisocial behavior, legal issues, unwed pregnancy. And minority status, female sex, and low income are found to be predictors of failure to be diagnosed and treated based on many studies that have in there. Now, next 2-3 slides are on Diagnostic Statistical Manual 5 version ADHD criteria. Here, we mainly see 6 out of 9 symptoms have to be there for children, and above 17 years and older, 5 out of 9 symptoms have to be present. In hyperactivity symptom category, same 6 out of 9 for children, and above 17 and older, it has to be 5 out of 9 symptoms. Since we are aware, I won't go over each and every symptom. It's important, and all of these need to be present in at least 2 or more settings. And the reason why it's important is because ADHD symptoms can be masked by structured environment, under close observation, if the child is frequently rewarded for appropriate behavior, if there is consistent external stimulation, or in interactions in one-to-one situations, such as in office settings. So if you are seeing a patient for ADHD assessment and you see the patient being engaged, then it doesn't necessarily mean that they, just because they're able to focus on reasonably well in your office setting, means that they don't have an attention. And all of these can affect the ability to diagnose a patient, and it's important that we see that the deficits are in more than two, at least two settings. And also important to note that in children, adolescents, they can be having school-related anxiety or bullying issues or peer issues at school, and they may be anxious. And in those situations, they may have trouble focusing in school, but not at home. So again, going back to the point that why it's important to see that its symptoms are there in at least two settings. And the presentation types are combined, predominantly inattentive, predominantly hyperactive, impulsive, specifies in partial remission, severity, mild, moderate, and severe. DSM-5 changes to the ADHD diagnosis are it is no longer a disruptive disorder, it's in the category of neurodevelopmental disorder. Symptom cutoff has been increased from age 7 to age 12. Autism spectrum disorder is not exclusionary, and we do not have any subtypes anymore. They are all presentations, inattentive, hyperactivity, or combined type. Differential diagnosis of ADHD. I have a list of psychiatric as well as medical diagnosis. All of these, it's important to note that all of these can also be comorbidities. The top on the list is oppositional defiant disorder, and up to 50% of ADHD individuals have ODD as a comorbidity. Next slide. This shows a comparison between children with and without ADHD in terms of coexisting disorder, and this was by 2007 National Survey of Children's Health found 33% of ADHD had one coexisting condition, 16 had two, and 18% had three or more coexisting conditions. So quite significant. And you can see such high percentage in children with ADHD as against without ADHD. And same in this slide, we see comparison in adults with and without ADHD, the coexisting conditions. You can see the percentage is quite high compared to those without ADHD. So it's quite there. Next few slides I want to spend on talking about how we differentiate or what are the similarities between some of the common comorbidities with ADHD. I'll start with ADHD and depression. Similarities are inattention, loss of interest, cognitive impairment, agitation, easy frustration, irritability. The features that distinguish depression from ADHD are the depression is pervasive. It is accompanied by neurovegetative signs. Lack of focus is only during the depressive episode, and in severe cases, you may hear them talk about suicidal ideations and all the criteria that we use for depression. So here, the most common and important symptom that we confuse or we need to look into is the inattention and lack of motivation. So when it's important to take a detailed history of a person who is complaining of inattention in order to help differentiate whether it's ADHD or depression, or it could be both. Is when you ask if I ask my patient about difficulty focusing and not able to do schoolwork, they might say, I'm not interested. So when you ask more in detail, are you not interested because it's hard to focus, or you just don't feel interested because you don't like schoolwork? So if they say, I'm not interested, I'm not able to focus, then it's more geared towards ADHD. If this, or sometimes even with depression, that you're not able to focus, if it's like not interested and also not motivated, then you want to make sure, is it difficulty focusing, making them lose interest and losing motivation to even bother to do any schoolwork, and in turn resulting into frustration about the whole idea of schooling and academics. So all of these are very important in digging into details of ADHD and depression. Next one, ADHD versus anxiety. So again, similarities are distraction, agitation, restlessness, fidgety behavior, frustration, impatience, anger. The distinguishing features are anxiety is in the context of excessive worry, stress, OCD symptoms, trauma, phobia. So more detailed history helps us in understanding whether it's one or the other. And again, we always have to remember it could be both. Next one, ADHD versus bipolar disorder. Similarities: distractibility, hyperactivity, talkativeness, impulsivity, irritability, mood lability. And the distinguishing features of bipolar are episodic symptoms with periods of euthymia when we talk about bipolar. As against in ADHD, the mood instability is there, but it rapidly subsides, unlike mood disorder. And when it's a mood episode, whether it's hypomanic or manic episode in bipolar, it's usually accompanied by flight of ideas, grandiosity, delusions, depending on how severe the symptoms are. Hyperactivity is goal directed, unlike in ADHD, which is not usually goal directed. We see pressured speech in bipolar. There is significant family history of bipolar or mood disorder, and also decreased need for sleep, which we wouldn't see in ADHD. And a prominent mood in bipolar would be irritable usually. And also, last important point to note is bipolar disorder is rare in pre-adolescence. So if you are trying to assess pre-adolescent for ADHD versus bipolar, then that is one point we can keep in the back of our mind. Then lastly, ADHD versus autism spectrum disorder. Similarities are distractibility, failure to initiate or transition or finish task, hyperactivity, easy frustration, and irritability. The distinguishing features are all of the key features of autism: repetitive stereotype movements, rather than just being restless and hyperactive in general, which we see in ADHD. So just observing more details of that helps in identifying the difference. Impaired social, verbal, non-verbal communication, lack of social relatedness, fantasy or social image or imaginative play, all of these autistic features and symptoms that we use to diagnose autism. And so the main confusion comes where failure to initiate or transition task, which can be seen in both. But usually in ADHD, because they have difficulty switching from one task to the other, they end up getting hyper-focused on a particular task and not able to switch a task, rather than in autism, which is a little different. And oftentimes I've been told by parents that my child plays video games for hours and he is able to focus on that and not have trouble sitting in one place for several hours. But when he has to do homework, he doesn't want to. So how can I just attribute it to ADHD? So that's where this hyper-focus theory of ADHD would come into play. Next, assessment. So assessment, psychiatric, medical. So in psychiatric assessment, detailed ADHD history, symptom onset, criteria, whether it's present in multiple settings, other history involving medications. Some of the medications like isoniazid, bronchodilators, neuroleptics, thyroid replacement medications can cause symptoms which appear like ADHD. Then developmental history, family, substance abuse history is important. Medical history, physical examination, height, weight, hearing, vision, signs of abuse, sleep disordered breathing, sleep apnea, sleep study. Sleep apnea can cause significant inattention symptoms, and sleep apnea treatment can help treat those. So it's very important. Fetal alcohol syndrome, Fragile X syndrome has significant ADHD comorbidity. Consider lab level EKG. ADHD rating scales. The adult ADHD rating scales commonly used are Vendor Utah rating scale, adult ADHD self-report scale, Connors adult ADHD rating scale. Assessment in children. Parent and child interview, a biopsychosocial assessment interview including family history. Parent and teacher completed child behavior rating scales. Now, among the rating scales, there are some narrow-based and broad-based rating scales. So Vanderbilt, Connors ADHD rating scale would fall under narrow-based rating scales. Eckenbach child behavior checklist, behavior assessment scale for children, BASC would fall under broad-based rating scale because they don't just assess for ADHD symptoms, but also for some mood and behavioral symptoms, which would include some comorbidities with ADHD. Direct behavioral observations of the child in natural and clinical settings is important. If a child is at a reasonable age where they are comfortable talking to you in an office setting by themselves, it would be worth spending some time alone with the patient to assess them and talk to them and observe how they are. Clinic-based psychological tests, attention tests, Corner's continuous performance test, test of variable attention can be considered. These are more to see the progress in treatment. Next, review of prior school and medical records, individually administered intelligence tests, educational achievement tests, or screening for learning disabilities if there are academic challenges. A standard pediatric examination or neurodevelopmental screening to rule out any unusual medical conditions that might produce ADHD-like symptoms is important. And additionally, vision, hearing screening, formal speech and language assessment as needed can be done. Now going to treatment. So my rest of the presentation, I'm going to talk about treatment of ADHD, comorbidities, and then focusing on stimulants before I end the talk. Treatment, I can divide into three categories: pharmacological treatment, psychotherapeutic treatment, and school and community resources for ADHD. Now, there have been some key studies in ADHD which have been of significance in defining the treatment of ADHD, and one very important one for children is multimodal treatment study of children with ADHD. In 1992, National Institute of Mental Health and Department of Education co-sponsored a randomized clinical trial which they named it Multimodal Treatment Study of Children with ADHD, MTA study. 579 children with ADHD combined type, age 7 to 9.9 years, were assigned to 14 months of treatment. It was the study had 4 arms: medication treatment, behavioral treatment, combined treatment, and community care. What they found was combined treatment and medication treatment alone were both significantly superior to behavioral treatment alone and to community care in reducing core ADHD symptoms. Combined treatment did not yield significantly greater benefits than medication treatment for core ADHD symptoms. Only combined treatment was consistently superior to community care in other areas of functioning such as anxiety, academic performance, oppositional behavior, and social skills. American Academy of Pediatrics guidelines suggest that for preschool age children 4 to 5 years of age, start with behavioral therapy as the first line of treatment, and if that doesn't help or if it's moderate to severe symptoms, then try medication approach. For elementary school age children 6 to 11 years of age, start with FDA approved medications and or behavioral therapy, or preferably both. For adolescents 12 to 18 years of age, FDA approved medication is recommended, plus behavior therapy, or preferably both. Now, in preschool age, medication is not contraindicated for children 4 through 5 years of age. However, dextroamphetamine is the only FDA-approved medication for use in children younger than 6 years of age. Now, this approval was based on less stringent criteria used in force when the medication was approved, rather than on empirical evidence of its safety and efficacy in this age group. Most of the evidence for safety and efficacy of treating preschool age children with stimulant medication has been for methylphenidate. And methylphenidate evidence consists of only one multi-site study called the Large Multi-Center Controlled Trial, the Preschool ADHD Treatment Study, PATS. It was the only multi-site study that carefully assessed medication use in preschool age children. What it did was it used short-term 5 weeks of trial to assess efficacy, and then followed by long-term 40 weeks studying for safety of methylphenidate in preschool age children aged 3 to 5.5 years. What they did was initially they enrolled all the children in intensive 10-week behavioral therapy program, which included parent counseling. What was found is 1/3 of the patients improved significantly and did not proceed to the medication arm of the study. So out of the 2/3 of the children that went to the medication arm, they entered the 5-week placebo-controlled double-blinded trial, which was about 165 children, and which showed benefits with methylphenidate in addressing the core symptoms of ADHD. However, the limitations were this group was one with moderate to severe symptoms, so mild. So medication was not studied in the mild symptom category in the study, and a few other points that were that came up out of the study was that a lot of children had severe or significant side effects from methylphenidate at regular dose compared to what it would be for older children. And also it depended on comorbidities, how the patient responded to the methylphenidate. It's like lesser the comorbidity, the better the response to stimulant. So that affected the outcome of the study. Now, this is the Texas treatment algorithm for ADHD. What it says is stage 1, you start with either methylphenidate or amphetamine group of stimulant. If that doesn't work, in stage 2, try a different stimulant. Stage 3 is if 2 trials of stimulant fails, you can try atomoxetine. After stage 4, buprenorphine or tricyclic antidepressants. And if stage 5, use any agent that has not been used in stage 4. And lastly, try alpha agonists. So this is the algorithm that is commonly followed. Next one is just a summary of treatment of ADHD and its comorbid disorders. Now, treatment of ADHD with anxiety. Start with ADHD treatment. If anxiety remains, start SSRI or even consider atomoxetine as the first-line treatment rather than trying the stimulant first. Some studies have shown that patients may be less likely to respond to atomoxetine if they have previously been on stimulant, irrespective of their response to stimulant, and that might give have thought of trying atomoxetine first. And another important point to note is stimulants can allow patients to access cognitive behavior therapy in ADHD patients by improving focus. So if someone has ADHD with anxiety who is trying to seek CBT, then stimulants can help improve focus quickly so that they can engage in therapy better. And secondary anxiety in ADHD is common because of their inability to handle their day-to-day life when ADHD is not controlled. So secondary anxiety improves with stimulant treatment as ADHD gets better. Treatment of ADHD with mood disorders. If it's depression, go with whichever is more severe. If ADHD is more severe, treat ADHD first. If depression is more severe, treat depression first. But if you go for treating ADHD first, it's important to closely monitor depression so that it doesn't worsen to the point of safety concerns or suicidal thoughts. In case of bipolar disorder, always do mood stabilizer first and stabilize the mood before treating ADHD. And one important point to note there is stimulants can worsen mood in many cases, and that is also one reason why it's always important to stabilize mood first. Treatment of ADHD with tics. Stimulants are not contraindicated in tics. However, there are studies which have shown that it can exacerbate tics for sure in some cases. So it's important to keep a close watch on that. If ADHD improves but not tics, then before making any changes to medication, you can hold off and not change treatment and closely monitor if tics are mild to moderate and transient. If that doesn't work, then change to a non-stimulant medication like atomoxetine, or if stimulant is working and very well, and it's highly beneficial for the patient, then add alpha agonist or add atypical antipsychotic or haloperidol. And of course, on the side, while you are trying all these different avenues, it's important to seek therapy like habit reversal training, which can always be additional support. Treatment of ADHD with aggression. Treat ADHD first. Determine whether aggression resolves. Oftentimes we see that when you treat ADHD, the aggression outbursts which are related to mood instability, emotional dysregulation mellows down and gets better, or maybe may subside completely, and you may not need any additional help for treating it. But if aggression persists, then add behavioral intervention, add an atypical antipsychotic to stimulant, add a mood stabilizer to stimulant such as lithium or divalproex, or add alpha agonist. And lastly, the treatment of ADHD with autism spectrum. Autism spectrum disorder is highly comorbid with ADHD. However, there's no medication that is specifically approved for ADHD with autism spectrum disorder. Because autism spectrum individuals are more prone to side effects, it's important to consider starting at low doses and gradually closely monitor and increase dose as needed. Sometimes some experts have also suggested or recommended starting with alpha agonist because it may have lesser side effect or effect on mood compared to stimulants. Now, before last few slides spent on stimulant and side effects, want to brief about just a mechanism of norepinephrine dopamine role. In order for the prefrontal cortex to work properly, moderate stimulation of alpha-2 receptors by norepinephrine and D1 receptors by dopamine is required. In theory, the role of norepinephrine is to increase the incoming signal by allowing for increased connectivity of prefrontal networks, while the role of dopamine is to decrease the noise by preventing inappropriate connections from taking place. If stimulation at alpha-2A and D1 receptors is too low, all incoming signals are the same, and making it difficult for a person to focus on one signal task. If stimulation is too high, incoming signals get jumbled up and resulting in misdirection of attention. So this is some background of how neuroreceptors are involved in ADHD and how stimulants and other medications may be acting on helping improve the symptoms. Stimulants and dopamine. Here the diagram shows a synaptic cleft. Genetic studies indicate that patients with ADHD have a higher rate of certain polymorphisms for dopamine and other receptors and for dopamine transporter, resulting in either low sensitivity of receptor or faster reuptake of dopamine molecules. Stimulant drugs inhibit reuptake, keeping each dopamine molecule longer in the synaptic cleft so that it is available to stimulate the receptors longer. Similar considerations apply also to norepinephrine, which is believed to be involved in ADHD. Now, talking about the stimulants, two categories, methylphenidate and amphetamine. In group clinical trials, both have been shown to be equally effective in treating ADHD symptoms. Studies showed 50% responded equally well to both methylphenidate and amphetamine, and stimulants have higher effective size than non-stimulants in studies. 75% of children benefit from stimulants, 90% respond after 2 medication trials. A large study of 3 million people, 15 to 42 years age in USA in 2017 showed significant decrease in substance use disorder risk in ADHD treated with stimulants. Now, it's important to note that at least 30% of ADHD individuals do not adequately respond to or cannot tolerate stimulant medications. While misuse of stimulants for treating fatigue can be accomplished by oral administration, abuse for euphoria typically requires snorting or injecting, and that's where greater risk is involved with immediate release form, and use of extended release may be more beneficial in people who have substance use issues. Methylphenidate versus amphetamine. Both block reuptake of norepinephrine and dopamine. by blocking their transporters, but amphetamine additionally increases the release of dopamine in the vesicles. Methylphenidate are approved about 6 years of age. Amphetamine, some of them are approved about 3 years of age. Some studies have shown side effects, and even in clinical practice, side effects are more common than with amphetamine than methylphenidate. However, methylphenidate can be more misused than amphetamine can be more misused than methylphenidate. And stimulants can be tapered without significant withdrawal. Rebound is possible, but usually at higher doses. It's important to monitor weight and height every 6 months. These are the list of immediate release and long-acting stimulants. Just last 2-3 slides on side effects. Loss of appetite is very common. If that happens, then it's important. It's commonly heard from parents that a child wakes up late in the night to eat, and which is normal because the effect of the medication wears off by evening. Considering short-acting versus long-acting can be helpful. Eating breakfast or lunch before taking the medication helps. Headaches, GI disturbance is common. Side effects usually last for about 1 to 2 weeks, and body gets adjusted, it gets better. Taking Tylenol can be helpful for headaches. If GI upset, do not take it empty stomach. Insomnia, melatonin can be helpful. If ADHD hyperactivity is causing to not let a child to go to sleep early at night in time, then adding alpha agonist can be helpful. Rebound can be managed by adding alpha agonist or Strattera. Seizures, it can lower seizure threshold, but it's not contraindication to its use. Side effects, effect on growth. Some reduction in expected growth velocity in height and weight can happen on an average, but it's small and it attenuates with time. Studies have shown that, for example, in MTS study, it has shown that there is decrease in growth velocity but it diminishes by third year, and on an average it's in the range of 1 to 2 centimeters. Some recommendations are medication holidays can lead to growth rebound, which is quite practically useful and recommended to parents. Pregnancy, category C, and lactation. Stimulants are category C medications. It can have teratogenic potential and found in breast milk. Exacerbation of psychosis is also a side effect, rarely observed in the context of either high dose or rapid increase in dose of stimulants. Exacerbation of tics can happen if the stimulant is helpful and no other medications have been beneficial. Then you can temporarily hold the dose or decrease the dose and re-titrate or add an alpha agonist. Stimulants should be avoided within 2 weeks of MAOI use. Caution in serotonergic medications, rare suicidal ideation risk. And lastly, stimulants and cardiovascular risk. Reports of unexpected deaths of children receiving stimulant therapy have led to concerns that these medications increase the risk of cardiovascular adverse events, including sudden and unexpected deaths. However, large cohort studies have not shown an increased risk of serious cardiovascular adverse events in children treated with stimulant therapy compared with the general pediatric population. Among adult patients who are either current or new users of stimulants, there appears to be no increased risk of serious cardiovascular events. And lastly, American Heart Association guideline states that detailed medical history is important, routine medical exam, monitoring blood pressure and pulse at baseline and follow-up. EKG is reasonable but not mandatory unless cardiac history is present. Main reason is because there are some false positives and non-specific EKG changes can be there, and which can complicate the picture and put a patient and family under stress. Routine check of Holter echo is not necessary. If patient is known to have cardiac disease or history of physical examination is suggestive of cardiac disease, further evaluation including EKG or consultation with a pediatric or adult cardiologist is needed. And ultimately, decision is based on risk and benefits. If it's absolutely necessary to treat with stimulants, then closely working with pediatrician or cardiologist can be helpful. And that's That's about it. Thank you.
Thank you, Dr. Desai. I want to remind everybody that if you haven't already signed in, you'll want to officially sign in the chat box in order to qualify for CME or CE credit. And then I did send out an evaluation form for CME and CE, which you'll be required to complete and send back to me to my email address that I had sent it to you from. And you could do that at the end of the presentation. I'm going to go ahead and introduce Barbara Farrell, and she's going to go into the next section of the course.
Hello, everybody. Go ahead and take a deep breath, stand up, shake out. That was a lot of information. I need the little control thingy. Oh, Dr. Desai. Okay, there we go. All right, so tonight I'm going to talk about a little bit about ADHD and substance use disorder, different prevention strategies that are out there, non-controlled medication used to treat ADHD. So Dr. Desai touched on some of that, and also nutrition and ADHD and some of the effects. So I put this in here because I felt like the Adderall Diaries that came out in 2009 and the movie that came out after that with James Franco really brought to public attention how Adderall had become misused in general society, almost the way that Driven to Distraction that came out in the 80s kind of brought ADHD to the fore of the public consciousness. So diversion versus misuse. Diversion is the selling or giving away of controlled medications. It can have legal consequences. Misuse, the use of controlled medication differently than it was prescribed or by another person than the person who it was prescribed to. So they're similar, but not exactly the same. In 2018, a study showed that there's low risk of 15-year-olds diverting their medications, but it could present an opportunity for prevention. Didn't see that in the other studies. It was more 5 to 9% grade school and high school age students misuse stimulants, and high school students at a rate of 9.5%. So the consequences, of course, when you're using any kind of a controlled substance is the risk of psychological or physical dependence. College students have the highest rates of misuse and diversion. Misuse is anywhere from 5 to 55%, and diversion anywhere from 2 to 29%. 59% of doctors suspect diversion. 74% have seen a client they believed was feigning symptoms to obtain stimulant. 2016 study, 1/3 of the physicians thought diversion was common or very common in adolescents. And in 2005, the ER visits related to stimulant use were 5,212. By 2010, that had increased almost tripled to 15,585. If we project that same rate into 2020, the number would be 410,909. Okay, ADHD and addiction. So when we looked at rates of ADHD and addiction let me start again. So when we looked at the population in a residential rehabilitation center, clients with ADHD and those without had very similar rates and amounts of usage. So they didn't differ there at all, but they didn't look at age. Substance use clients with ADHD use cocaine and marijuana at a much earlier age. And the younger the age of the first use was associated with heavier usage. Younger age also was associated with the younger age of admission to rehab. So they may have been using as much, but they may have been much younger than the other people in rehab. The big difference was the rate of ADHD in the rehab population versus the general population. It was almost 12 times as much. Dopamine imbalance and nicotine. So Dr. Desai touched on imbalances of dopamine in the prefrontal cortex, both in ADHD and schizophrenia, are hypothesized to have those imbalances with dopamine. Nicotine can cause a release of dopamine at a much higher rate. And the tar, if you're smoking, keeps that dopamine active in that neurosynapse. Smoking is the fastest delivering system. The population of people with ADHD have a similar rate of smoking tobacco as schizophrenics. This is double the rest of the population. Okay, how do we prevent the misuse of stimulants? A number of different strategies, from controlled substance patient agreements, patient education materials, prescription of long-acting versus short-acting stimulant medications, and Dr. Desai touched on that. Much easier to misuse the short-acting than the long-acting. Prescription of non-controlled substances for ADHD, and limiting the number of pills to a monthly supply and/or pill counts. I'm going to start with physician perceptions of the effectiveness of prevention practices. So in that first column on the left, at the very top, there's 1.4% of physicians feel that using a medication contract is very effective. Distributing print materials or patient education, 3.1% thought it was very effective. 22.8% of physicians felt that limiting the prescription to the smaller number of pills was very effective. 30% thought employing pill counts was very effective. 34% with prescribing long-acting stimulants, and the biggest by far, 71%, prescribing non-stimulants was the most effective. Controlled substance agreements is the first thing I'm going to go over. It's a pretty busy slide. There's a lot of stuff on there. Basically, I'm going to try to just hit the high points of these. You can find lots of different ones online. They come in different emphasis on different points. I usually use the controlled substance agreement as a launching point for patient education. Don't have a lot of good print handouts that I could even find. So when a patient signs the controlled substance agreement, they're agreeing to attending appointments in a timely manner, connecting with staff if they're unable to come at the agreed upon time. They're agreeing to safe storage of their medication. So keeping it safe from misuse, diversion, being stolen or lost, taking the prescription only as prescribed, and no early refills. Treating the office staff with respect. I think that that's an important one. They're agreeing not to misuse or divert the medication. Many of them have a release so that the provider can speak to other physicians on the client's team of caregivers. And I want to mention the Cures database, which is a national database for controlled substances. So it used to be that clients could pay cash both for their appointment and for the substance, use different pharmacies, and that way have multiple providers giving multiple controlled substances. But with the Cures database, that's no longer the case. Next page, more of the controlled substance agreement. Patients are also agreeing not to use street drugs or illegal drugs. They're also agreeing to drug tests often and pill counts. And the drug testing not only tells us if they're using other medications that they're not supposed to be using or street drugs, they're also telling us if they're using the medication that we prescribed for them versus diverting it. Also, they agree to stay current on bills. Now, the last part here is the part that I think is really important as well, is the commitment of the clinic or the provider to the client to take good care of them. So it goes over those responsibilities of making sure they're available for follow-ups when they get scheduled, not having their schedule so full that there's no room for that follow-up, or if they need to reschedule, making sure that the client doesn't run out of medication in between the appointment and the next appointment. Even if they have to cancel, the client has to cancel, move it out a week, giving them a week's worth of medication until they're seen again. Also communicating between other providers, giving that case management team approach, and referral to rehab if needed. Okay, how often do these prevention tools get used? A 2004 study showed that when physicians suspect misuse, 23% performed pill counts, 36 medication agreements, 19 offered educational materials, 50% prescribed non-controlled treatments, and 51 referred to treatment if substance abuse was evident. So 2017 study showed that 46% of physicians educated patients often, 44% very often on the health risks and legal consequences of using controlled substances. The good news is the more stimulants a physician prescribed, the more likely that they would do patient education. The reason why so few of physicians use these tools is because there's little to no research on how well they actually work. Okay, non-controlled substance treatments for ADHD. Most of these you work on those same neurotransmitters that Dr. Desai was talking about, norepinephrine, dopamine, and alpha-2 agonists, because I don't know if you're going to be able to see this. So none of the nerves in our body are hardwired together. They all have that neurosynaptic gap. The electrical signal comes down, the neurotransmitter is released, certain levels hit, this one takes it, transmits it into an electrical signal, and that signal goes on, right? So these neurotransmitters are ubiquitous throughout the body and do different things in different parts of the brain. We'll talk about that in a little bit. Okay, so here is another fabulous example of Stahl's great way of simplifying some of these incredibly complicated concepts. So this right here is supposed to be a nerve. And Dr. Desai touched on this, that if the optimal level of dopamine isn't in that neurosynapse, there's going to be more background noise or static. She also talked about how the suboptimal level of norepinephrine causes that signal to be weak. When you optimize both of those, then you see that, there we go, those students who were fidgeting and shifting attention can now sit in their seat and pay attention to what we want them to pay attention to. So that's this optimal thing with treatment. So treatments with a stimulant cause an increase in the dopamine concentration. They don't always hit the norepinephrine. So it can increase that noise, but not necessarily reinforce the signal. And that's where the alpha-2 agonists can come in as augmenters. First medication, Wellbutrin. It is a medication that affects the dopamine and the norepinephrine. Dosing is from 75 to 450 milligrams. It takes 2 to 8 weeks to become fully effective. So unlike the stimulants, it takes that long time. It doesn't act immediately the same day. You can't take it as needed. You do have to take it every day. There are some GI side effects, headaches, tremors. The big thing to remember is that this is not a suitable medication for somebody who's had a history of seizures, because it will lower the seizure threshold. It also will decrease appetite, so it's not suitable for people with history of eating disorders. Okay, so this is a picture that shows us how the effects of the alpha-2 agonist work. So basically, if you look at that upper left-hand neuron, you see that we don't have that optimal norepinephrine concentration. So the noise and the signal are kind of equal and hard to focus. At the bottom, it shows that optimization of the norepinephrine and the dopamine. And you see that the background noise is decreased while the signal is increased. What this is it shows up here, that's a little box of one little dendrite off of that neuron. And it shows that when the norepinephrine plugs into that alpha-2 receptor, it will plug that channel. So let me just back up. So here, where there's a suboptimal level of the norepinephrine and the dopamine, that signal kind of leaks out that channel, and the surviving signal strength is pretty low. But when the norepinephrine is right and plugged in there, it will block that leakage. Okay, Strattera is a selective norepinephrine reuptake inhibitor. Dosing for adults is 40 to 100 milligrams a day. Children, 0.5 to 1.2 milligrams per kilogram per day. Norepinephrine receptors in the prefrontal cortex actually regulate dopamine as well. So it may be just a norepinephrine reuptake inhibitor, but it also increases the level of dopamine in the prefrontal cortex. Now, there aren't very many norepinephrine receptors in the nucleus accumbens, and that is basically the reinforcing area of the brain with any kind of controlled substance that could be addictive. So what this means is that while the norepinephrine reuptake inhibitor can increase it in the prefrontal cortex, it's not increasing it in the nucleus accumbens. So the ability for it to be misused is low to non-existent. It works 24 hours a day, but it is another one of those medications that you do have to take daily, and you do have to wait a little bit for it to kick in fully. Also, it's Stahl hypothesized that long-term inhibition of the norepinephrine in the PFC can be beneficial, and it can restore the tonic postsynaptic dopamine 1 and alpha-2A adrenergic signaling. Okay, clonidine. I know I've got it here. There we go. So this is an alpha-2 inhibitor. It has actions at alpha-2A, alpha-2B, and alpha-2C, and imidazoline. Actions at 2A are the therapeutic thing that we're looking for with ADHD. 2B, 2C are responsible for side effects. Imidazoline also cause sedation and blood pressure lowering. The dosing's between 0.1 and 0.4, so you can see it's quite potent even at tiny doses. The FDA has not approved it for treatment with ADHD, oppositional defiant disorder, or Tourette's, but it's often used off-label for those. We also use it for hypertension and or opioid detox. Side effects, again, GI side effects, tachycardia, nervousness. Guanfacine is also a alpha-2 inhibitor, but it's an alpha-2A receptor agonist only. So with the dosing, it's 1 to 2 milligrams immediate release. Extended release is 1 to 4 milligrams. The mechanism of action, again, is a norepinephrine receptor agonist. It enhances prefrontal cortex functioning, memory, attention, impulse control, and planning. Side effects can be sedation, GI side effects, etc. Okay, so other non-stimulant treatments for ADHD, MAO inhibitors. This was the first antidepressant, requires very strict food restrictions, and can lead to overdose. It was sidelined a little bit when the tricyclic antidepressants came along. They were the second antidepressants. However, those also can be lethal in overdose and require EKG monitoring in children. So both of those were kind of kicked to the curb when the serotonin reuptake inhibitor antidepressants came along. But both of them can be that fifth line intervention for ADHD. Antipsychotics can work when stimulants or the MAOs or TCAs don't work. Anticonvulsants can help with comorbid disorders, aggression, explosiveness, and impulsiveness. Now we're going to talk about nutrition and ADHD. I found this in the Feingold Blue Book. Basically, it's the Yummy Foods Corporation. We want the product to be attractive, nutrition, and tasty, even if you have to add food to it. So nutritional influences. Nutritional influences have a stronger influence on children of preschool ages than teenagers or adults. Low levels of zinc, iron, and magnesium are associated with hyperactivity or inattention, and low levels of serum ferritin are also associated with hyperactive behavior. Low levels of omega-3 polyunsaturated fatty acids can predispose children to ADHD as well. Supplements can ameliorate some of these symptoms of hyperactivity, but it's important, especially with the omega-3s, that you don't overcompensate. And when you're under high stress, B vitamins are always helpful. The Feingold diet. So this came about in the 1970s and early 1980s. Benjamin Feingold, Chief Emeritus, Department of Allergy, Kaiser Permanente Center in San Francisco, California, noticed that his patients who were sensitive to artificial food additives were greatly improved their ADHD symptoms when that got taken out of their diet. You may remember it excludes artificial color, flavor, sweeteners, salicylates, MSG, nitrites, nitrates, sulfites, sodium benzoate, corn sweeteners, calcium propionate. It was recommended that the whole family adopt this diet approach and that most foods were made from scratch. You can see that's kind of an arduous thing to take on. The reason why I listed the common foods that interact with artificial food additives, because even small amounts of those artificial food additives that normally a child wouldn't react to can almost be amplified by milk, chocolate, or wheat. Oh, wrong way. Okay, some studies that came right after disproved Feingold's results. In 2004, Schaub and Trim did a meta-analysis of the studies and said that it's very difficult to study the effect of artificial food additives without knowing the exact physiological processing causing ADHD. Subjects may have had inadequate washout periods, so if they weren't without those artificial food additives for long enough, they wouldn't see a difference when they were reintroduced into the diet. Children with an actual clinical diagnosis of ADHD had bigger reaction to artificial food additives than those who did not, who were included in some of those studies. Learning and attention was affected within 2 hours of the artificial food administration. So if that was given at breakfast and they didn't check till mid-afternoon, they might not see a result. Many of the doses in the studies were less than a child's normal daily exposure, and the larger doses of AFAs, the more the children were affected. Wanted to include this. There are 6 artificial food additives that the FDA in the US have approved, but in the EU, they have this warning label. In 1955, the limits for AFA was 12 milligrams per capita per day. By 2010, that limit had increased to 62. Okay, if you have any questions, put them in the chat box and we will answer them at the end. And here's references.
Thank you, Barbara. Next up, we have Aubrey Vance-Tovry.
Hi, everyone. Thank you so much for joining us tonight. Hopefully you're hanging in there. I know this is kind of a long presentation. So my name is Aubrey Vance-Tovry. I'm a psychotherapist here at Siyan. I work 50% of my time with adults suffering from anxiety, depression, bipolar disorder, ADHD, and trauma. And then the other 50% of my time, I work with patients who are recovering from opioid dependence on medication-assisted treatment through our Project HOPE program. So my goal is always, no matter what I'm treating, is to help a person live a fulfilling life not defined by their diagnosis. So although my colleagues and I are covering different aspects of ADHD, you'll probably notice some overlap with information. So let's get started. According to the National Institute of Mental Health, 4.4% of adults are diagnosed with ADHD, with 4.5% of adults being in ages of 18 to 24 and 4.6% being the ages of 35 to 44. About 1/3 of the adults diagnosed with ADHD have sustained the diagnosis since childhood. There's quite a bit of controversy around diagnosing ADHD in children. However, I think the mental health field is doing a lot better at getting an accurate diagnosis by gathering an extensive history. And actually now some experts believe that ADHD is underdiagnosed and we're overlooking some obvious symptoms. The National Institute of Health did a research study on adults who were underdiagnosed, and they found that oftentimes it gets overlooked because many of the people presented with chaotic lifestyles and impairments, which could be attributed to drug use or other mental health disorders. And we'll talk about that a little bit later. So as we look at this picture on the slide, we see 3 different types of ADHD, inattentive, hyperactive, and impulsive, and the combined. The symptoms differ with each type, but the most common symptom that I hear from my patients as a therapist is that it's incredibly hard to focus on one task at a time. They're often very hard on themselves, blaming themselves for procrastinating on something that they know is important. And they might say something like, I don't know why I keep doing this to myself. I just want to get the dishes done or clean my room. And I have one patient who actually struggles with rushing through tasks at work. So that's another common symptom. She continues to get feedback that the task is done incompletely, and she just continues to keep rushing. And so we work on that together in therapy. ADHD oftentimes leaves people feeling so frustrated with themselves. And so later I'll talk about some therapeutic interventions that are helpful and effective in addressing the symptoms to help them live a more fulfilling life. And just for reference, I work only with adults, so 18 and older. I don't work with children. So a lot of my interventions and information is going to be based only around adults. So research shows us that ADHD looks different in males and females, with males being diagnosed more than females. About 5.4% of males are diagnosed with ADHD compared to 3.2% of females who are diagnosed with ADHD. So we have to ask ourselves, why is ADHD diagnosed more in males? Well, and as my colleagues mentioned earlier, if we compare the symptoms, which ones do you think get the most attention? The externalized symptoms are definitely more obvious. So we see males with symptoms of inability to sit still. They're more physical, maybe a little bit more aggressive, whereas the female might be more withdrawn and she's quiet. She'll have difficulty concentrating or paying attention. And that's not to say like it's all or nothing, just these are some of the overall arching themes that we see. So as a result, oftentimes we see females have low self-esteem and they're more withdrawn, thinking that they might be different from their peers. So it's quite possible that ADHD is underdiagnosed in females due to symptoms presenting much differently. And it's unfortunate because many times female adults don't get treatment until they're in adulthood. And I can't imagine how life would have been different for them had they had an intervention at the age of 6 years old. If they had had medication and therapy to learn how to better function and to focus on tasks. So we want to try to improve our screening as early as possible to get people support. As I mentioned earlier, ADHD can be difficult to diagnose because symptoms might overlap with other disorders. So this is why gathering the patient's history is so important, and using screening tools such as the adult ADHD self-report scale to get an accurate picture of the person's impairments. So I want to talk about Tommy. He's my fake patient for the night. We're going to grow real fond of Tommy. He was referred to me by his healthcare provider for therapy because he's struggling at work and in his relationship. He's had a hard time sleeping and constant energy. The first thing we want to do is gather his history. So Tommy's a 25-year-old male. He grew up in a family of 4 children with a lower socioeconomic status in San Diego. His parents divorced when he was 10 years old, and he was exposed to domestic violence in the home growing up. Tommy's dad had an alcohol use disorder and his mom had bipolar disorder. He says that he was the kid that always got in trouble in his family. His parents were yelling at him to clean his room. His other siblings didn't really get in trouble, so he always thought he was the black sheep. He struggled in school, and his parents were called for parent-teacher conferences, but they couldn't make it because they both worked. And at 12 years old, Tommy was referred to a psychologist, and he was diagnosed with a learning disorder called auditory processing disorder. The learning disorder was justified because he had difficulty completing his assignments and he was constantly talking with other kids during the class. He recalls this experience as a confusing time in his life. He told me he just thought he was bad at school. He could hear the teacher talking, but was thinking about different things all at the same time. He did love recess, though. Tommy was eventually referred to counseling at school because his parents' divorce was nasty, and that's how he put it to me. He didn't really go to therapy, and his parents didn't reinforce it because they were busy dealing with the divorce and working full-time. So at the age of 16, Tommy started ditching class, hanging out with his young adult friends outside of school and the neighborhood. And this is when he was first introduced to alcohol. He said it just started with a couple of beers with the guys, and then it was marijuana and cocaine. He said that he remembers that day when he tried cocaine for the first time. It was like he finally felt relief. He continued to use cocaine off and on until he dropped out of high school and got a job in a restaurant. He noticed that he was able to focus better when using it, and he cooked faster than everyone else in the kitchen. Eventually, cocaine became too much to afford, and his friends and family became suspicious of him borrowing money all the time. So then he tried using methamphetamines. It was cheaper. And he's 20 years old at this point. He said he never thought he'd be one of those people who used it, but it became so addictive that he needed it to get work done. So when Tommy wasn't on methamphetamines, he noticed it was different. His boss was yelling at him to get back to his workstation. He's jumping around to different tasks. He said he's just slower and he feels like he has a hard time focusing on one thing at a time. Tommy told me about his girlfriend that he met at the restaurant. He cares a lot about her. He's in love with her. But she recently found out he was using meth, and so she said she was going to break up with him if he didn't get help. And so that's why he's here in my office seeing me. So that's the story of Tommy. I think we can all agree Tommy has been through quite a bit in his young life, and he presents with some obvious symptoms that at first make us think he has maybe only amphetamine dependence, that causes him to struggle with sleep and to feel anxious. But I wonder if he was misdiagnosed as an adolescent with a learning disorder when it could have been ADHD or complex trauma. So it's clear that before I continue therapy with Tommy, he'll need a referral to detox to manage his withdrawal and then to drug and alcohol treatment. And, I'm going to want to see, how does Tommy present with methamphetamines out of his system so I can get a clearer picture of what's going on. After he finishes treatment, I'm hoping that I can re-engage Tommy, collaborate with his provider and get him on some medication, and we can have him take the ADHD self-report scale and determine if he needs to be referred back and start some medication. So that's my initial treatment plan with Tommy, and I do end up seeing him again, so stay tuned. In the previous slide, we saw how ADHD symptoms overlap with other disorders. I briefly touched on them. But overall, I think that we kind of see overlap, and as Dr. Desai said, we're going to figure out, what do we need to treat first? Is it the depression or is it substance use? In Tommy's case, we referred him to treatment because substance abuse was the primary issue, although we do think that there's some underlying issues going on. So, once we take that into consideration, then we can start moving on and really treat the problem. So it's rare to find out that ADHD is a diagnosis on its own, but we can't talk about any disorder without talking about trauma, and especially if you're talking to me, because it's something I'm known for. So trauma symptoms look similar to ADHD, as we see difficulty concentrating, we see impulsivity, withdrawn, isolating behavior, and low self-esteem. And we can't ignore that trauma that impacted Tommy throughout his childhood. So what if we had approached Tommy first with an ACEs questionnaire? How might my conversation been different with him in my office? And not to say that my conversation went bad, it went really well. I just want to point out that it's important to screen for and diagnose complex trauma or PTSD. And so for those who aren't familiar, the ACEs questionnaire was developed out of a research study done by Kaiser in 1995. And it measured adverse childhood experiences, such as abuse and neglect and household challenges, through questionnaires when visiting their primary care. The study showed us that The higher an individual's score, the more likely the person would experience health problems and other negative outcomes in their life. So this is important to note because we're determining the diagnosis in an individual. And if we don't consider treating all of the underlying trauma, we aren't really solving the problem, just treating the surface level symptoms. In a research study published in the Academic Pediatrics, Dr. Brown surveyed 80,000 children and found out that parent-reported ADHD had higher ACEs scores than those who didn't have ADHD. In her research, Dr. Brown suggests that if the underlying trauma was treated, we would see better outcomes and improved symptoms with children who had ADHD. So as we noted earlier, one of the more notable symptoms of ADHD in females is low self-esteem. This isn't to say that males don't experience it, but in my experience, majority of male patients have low self-esteem related to more than one area of their life. And mostly I see it interfere in relationships. In the book Driven by Distraction by Dr. Hallowell and Dr. Rady, they talk about this endless cycle in families and relationships. The person with ADHD is disorganized or forgetful, as you can see here in the top circle. And then the other person becomes upset and puts the person with ADHD down. Then the person with ADHD withdraws or they act out. And then the other person reiterates, sometimes passive aggressively, and what their expectations are again. So it becomes this endless cycle that causes people with ADHD to become so frustrated with themselves and with others. These are the complaints that I hear in my office. The way that they relate to the world is through, sometimes through a lens of shame and guilt. And they might think, what's wrong with me? I must not care enough to get this done. I must not love this person that much. I'm different than everyone else. And as providers, we need to look at how we can use different interventions to break the endless cycle so we can stop the unnecessary shame and guilt. So there are many different theories and approaches out there, and it can be frustrating to figure out what approach will work best for you and your patient. So don't worry, I did the research for you, and I have firsthand experience in seeing how effective the evidence-based interventions can be with patients. So the next few slides, we're going to be covering trauma-informed care, cognitive behavior therapy, dialectical behavior therapy, social skills training, and mindfulness. Just to make sure we're on time. So there's so many different theories and approaches out there that it can be frustrating to figure out what we're going to do. And so let's start with trauma-informed care. And before jumping into any intervention with a patient, we always want to use trauma-informed care. I think this quote about trauma best describes how a patient experiences the world after experiencing trauma. I often describe it to my patients as if they're wearing eyeglasses that have gunk and smudges, making it hard to see clearly. And so I say that therapy will be a start to helping them clear that lens and help them see more clearly in the world. So how I use trauma-informed care with patients who have ADHD is first by how I show up in the room. I think to myself, what kind of trauma could be at play here? I want to be as attuned as possible to the person in the room. I want to be curious about their history. I want to provide consistency and choice-making opportunities and use strength-based person-centered language. The way I use trauma-informed care with Tommy, we're going to bring Tommy back, is something like this. So, Tommy, it sounds like other people had a hard time understanding you when you were younger. I'm sorry that experience happened to you. How can I better understand you? And then when collaborating on his treatment plan, I didn't say, Tommy, you need to go to drug and alcohol treatment. You know, we got to get this taken care of. I said, Tommy, it sounds like your main concern is that you want to get off methamphetamines because it's causing you a lot of stress in your life. So let's look at some of the options you can choose from so we can get this addressed. I then would explain to him the benefits of outpatient or inpatient treatment, residential, and I want to let Tommy have the agency. I want him to make the decision himself whether or not he's going to go to treatment. And it's so much more impactful. So one of the most recommended interventions for ADHD is cognitive behavior therapy. This therapy is effective because when used to fidelity, it provides structure and consistency. And consistency is key when working with someone who has ADHD. Their world is already unpredictable enough with their own distraction, impulsivity, and frustration. So we want to eliminate that experience as much as possible. So when I meet with Tommy, I would start every session with doing a mood check. I would say, tell me about your week. What did you notice about your mood this week? And this might be a 5 to 10 minute check-in. And it's our responsibility to hold the patient accountable. We want to make sure that we're providing some structure and redirecting them back to our agenda, and just in case he starts to go into a little bit longer of a story with his mood check. And then the next thing, I'm going to bridge last week's homework to the current session. I'm going to ask him, how did it go practicing? Did you notice anything about your thoughts this week? Did he write down one scenario we talked about? And if he didn't do his homework, I'm going to ask him if we can add it to our current agenda. And most of the time, we only have about 30-40 minutes, as we know, in session. So we want to address probably only 1 to 3 items on the agenda. In the last part of the session, we're going to review our action plan for the week. And this is where we're going to collaboratively assign homework together. We want to make sure that Tommy has agency once again in deciding what the homework might be. So whatever we went over, if it's looking at thoughts, or we'll talk about more interventions with CBT in a sec, but that he can choose what's realistic. Is he going to catch 2 thoughts this week? So here we can see the essence of cognitive behavior therapy. It's an event that happens, and then a thought is triggered. So our thoughts cause emotions, they cause physiological experiences, and that's what we feel in our body. It's like our heart rate or sweating. And then we respond by acting out in a behavior. So let's jump back into session with Tommy again. One time he told me about this time at work that his boss got mad at him for continuing to leave his workstation. So of course I explored it, wanted to figure out what was going on. And the way Tommy told the story was like this. He was working on the grill this one day and he noticed that they were running out of plates. And he saw his coworker was taking a break. So he jumped over to clean some dishes and his manager stormed over and was mad at him. He was all over him, just yelling that he was burning the meat on the grill. So he got so mad that his manager was talking to him and he stormed out of the kitchen. The first thing I did was validate Tommy. I want him to know that I'm on his side and also willing to take a look at what his behavior was. So that must have been really frustrating for him. He wants to be a team player and his manager didn't recognize it. So next I'm going to use the cognitive model to break down his process. Tommy and I identified the event, started when he left his workstation to the dishes, and then his manager yelled at him. Then I asked Tommy, what is the thought when he was getting yelled at? Tommy identified the thought, no one ever appreciates the hard work that I do, which resulted in him feeling resentful and angry. So as we're even sitting in session, he noticed his body getting tense, and the only thing he could do was leave the situation. Stay tuned on what happens with Tommy. So when we use the cognitive model to break down the patient's experience, their worldview starts to change. They have more awareness about how they show up in life and feel more of a sense of control over their reactions. Using the 3 C's is a fun way to slow down the process and evaluate what can be different. A lot of times our patients don't have awareness about thoughts. So first I like to say that the 3 C's can be useful when patients notice an unwanted emotion, such as like jealousy or sadness. And once the emotion is identified, we'll reflect on what happened right before, and that's called the trigger. So what thought did Tommy have? He said, no one ever appreciates the hard work that I do. So I challenged this perspective. I'm going to ask Tommy, what's the evidence that his manager doesn't appreciate his hard work? And actually in our session, he couldn't find any. In fact, he told me that he won the Employee of the Month award. So after looking at evidence, we started exploring an alternative, more helpful thought, and all on his own. Tommy said that it's really important that he watches the meat and that he doesn't burn it. So he recognized where his behavior went wrong and that it was actually due to ADHD symptoms of feeling distracted. So I noticed in session, Tommy became more open, he was understanding, and I asked him what emotion he was experiencing when he had that thought. And of course, it was different. He felt relief, and he didn't take it so personal as that he had thought before. So obviously, I'm talking best case scenario here with Tommy. I know that not all patients respond in this way. I think in times where patients are resistant to checking the thought or evaluating it, we may want to offer a suggestion. Another helpful intervention for ADHD symptoms is dialectical behavior therapy. And so experts suggest using emotion regulation skills and distress tolerance skills to help with symptoms of frustration and disorganization. My favorite concept from DBT is the wise mind skill, as you can see here on the slide. So patients tell me that this is eye-opening for them when they learned what they tend to be a little bit more. Are they more on the emotion side? Are they more on the reason side? So it helps them feel more balanced and mindful when they're using wise mind. It's that place of intuition. And we'll talk more about mindfulness in a minute. So all the DBT skills basically stem from this idea of mindfulness, bringing it back to the present moment. So I'm not going to talk about Tommy anymore in this slide, but just for your knowledge, Tommy did great. He graduated therapy with me. He was learning about CBT, and he actually broke up with his girlfriend who wanted him to go to therapy. So, and he was on medication as well. And so now let's look at some of the interventions on the left side of DBT. So emotion regulation, the first one that is recommended by experts is check the facts. That is a 6-step questionnaire. And it basically just asks the person to evaluate whether or not their emotions fit the facts. For example, if someone responds defensively, they probably felt some sort of threat that felt personal. So we want to check the facts. It walks them through questions and it asks them, like, is the threat you're assuming, is it real or imagined? The next skill is opposite action, and it's just how it sounds. This skill prompts the person to check in on their emotion and the action it causes. So if the behavior is helping them work toward their goal or isn't helping them work toward their goal, they will do opposite action. And it changes their emotional response. The next skill is called the STOP skill, and I think this one has been really popular actually during COVID for helping people reduce anxiety, but it's commonly used with patients who have ADHD. So it stands for stop, take a step back, observe what's going on inside of you and outside of you, take a deep breath, and then proceed mindfully. The last skill that is helpful in getting patients with ADHD to tolerate the moments is self-soothing. There's lists and lists of self-soothing exercises, but we can use this skill if we remember that it all comes down to our 5 senses, and that's taste, sound, sight, touch, and smell. And some of my favorite are opening a bag of coffee and smelling the aroma, or taking a hot shower with lavender soap. I think that can be really relaxing for a patient, and so I always recommend that. Self-soothing is a form of mindfulness, and it helps bring our awareness to the present moment, and it activates our parasympathetic nervous system. It's that feeling of calm and relaxed versus the sympathetic nervous system, which gets activated and feels like there's a threat. Oftentimes people with ADHD have that feeling like there is a constant threat because of all they've experienced in their life with not being able to regulate their emotions. So many patients with ADHD receive feedback that they interrupt in conversations and they talk over people or are not paying attention to social skills. So I like to role play with my patients in the office, have conversations, and have them practice using nonverbal communication. So you can see all the different points on here. We have eye contact. Oftentimes we see eyes kind of darting around, and I really want to help them use mindfulness, bring it back, and look at people in the eyes. We're going to help bring awareness to body movements, of the fidgeting, help them learn how to sit still and just be in their body. Noticing facial expressions. So I think learning social cues through facial expressions. If someone looks like they don't want to talk anymore, what does that look like? And then also paying attention to voice volume and tone. Not everybody has this issue, but sometimes I have met with some people who tend to get a little bit louder, they get excited, and so we learn how to just take it down a notch. Other nonverbal skills or social skills are active listening. That's showing interest by nodding your head. We'll teach them how to repeat what the other person says in your own words. And so a lot of times I'll tell a story and then I'll have them reflect it back to me. And assertive communication. It's important for people to learn how to ask for what they need and express how it makes them feel. So this is going to be our last slide, and then I'll close with a little exercise for us. In a research study published by Dr. Zalowska, she followed 25 adults with ADHD and had them do 8 weeks of mindful practice. A majority of the adults noticed an improvement with focus and attention. So I thought this quote was a powerful quote from the study because I think it shows us that we can make an impact with our interventions and help improve functioning with people who are living with ADHD. So as our time comes to a close, I want to guide you through a quick mindfulness meditation. It's only going to be a minute or less. I'm a believer that we should practice what we preach. And so let's take a minute to step into their shoes. So first, I want you to sit in a way that is alert yet relaxed. Close your eyes if you'd like, or direct your gaze downward, gently softening the visual field. Establish yourself in a comfortable seated position. Notice your body and your feet on the ground, any sensations in your body while you're sitting. Notice your legs and your torso as they make contact with your seat or the ground. Also notice your posture. See if you might sit in a way that's upright but not rigid, relaxing into your body and breathing normally. Begin now to notice your breath, directing your attention to the experience of breathing. The sensations of the in-breath and the sensations of the out-breath, noticing the air coming in and out of your body. Firmly but gently, directing your full undivided attention to this experience of breathing, whatever that means to you. Notice the air coming in and out of your body. Pay attention to this full cycle of breathing. If you've noticed your mind has wandered, that's perfectly natural. The mind may wander away many times. And if you've noticed your mind has wandered from your breath, take note and gently but firmly bring your attention back to your breathing. Come back to the experience of in-breaths and out-breaths and the full cycle of breath. This is the process of focused attention on the breath. So stay with the breath as we draw this practice to a close. And I'd like to invite you to take 3 slightly deeper breaths at your own pace. And whenever you're ready, you can open your eyes and bring your awareness back to the room. So thank you so much for joining me today. And I hope that you're able to get some helpful information on how to work with people who have ADHD. Thank you.
How are you taking people?
Hi, my name's Amanda. Thank you guys. Thanks, Aubrey. I wanted to go over, we have a few more minutes and I have a couple more slides on an introduction to our program. It's called Project Hope. We have a medication-assisted treatment program. And studies have found that with adults who have ADHD, they're more likely than their peers without ADHD to develop a substance use disorder sometime during their lives. We heard a lot about stimulants and ADHD. However, we also see patients who have ADHD that self-medicate with opiates. So I think about symptoms of ADHD such as difficulty regulating emotions or distress tolerance and hyperactivity. Some people say they just like to shut it off. Opiates would help people with ADHD slow down their internal process, but unfortunately, that self-medicating sometimes turns into an opiate use disorder. Untreated ADHD in adults can not only lead to significant problems with education, social and family situation with relationships, employment, self-esteem, and emotional health, but can also contribute as a factor to maintaining a successful recovery. So Project Hope, it's a medication-assisted treatment program. We target crisis rates of opiate use disorders amongst residents ages 18 and older in rural area of Northern California. It's a federally funded program through SAMHSA and CSAT, Center for Substance Abuse Treatment. It's an outpatient medication-assisted treatment program. We offer Suboxone treatment, Sublocade, which is an injectable buprenorphine, naltrexone, and as well as Vivitrol. We serve an average of 100 adults annually. And some of the services we offer through our program is weekly physician visits for medication management, weekly individual and group therapy with a substance use disorder counselor, individualized treatment plans designed by a managed case manager, and we utilize 7 evidence-based practices such as motivational interviewing, stages of change, CBT, trauma-informed care, intensive case management, relapse prevention, and 12-step facilitation therapy. So a couple of the desired outcomes that we strive for is an increase of the number of individuals with OUD receiving medication-assisted treatment, and then a decrease in illicit opiate drug use and prescription opiate misuse. So those are a couple things that we always shoot for. And that wraps up our presentation for today. Thank you guys. If you guys have any questions, make sure you enter them into the chat box. I do want to mention, if you're attending this course for CME or CE credit, you do need to officially sign in if you haven't already. I think I saw everyone had signed in, but sign in the chat box, and then you'll want to complete your evaluation form that was attached to the email. So for CME, that's usually for MDs. And then as you can see here on the screen for CE, it's like a PhD, MFT, LCSW, and etc. When you're done with your evaluation form, you can do it now and then email it to my email address, and I'll return a certificate of completion for self-reporting. Okay. And that wraps it up. Helen, do we have any questions?
Yes, one for Dr. Desai, and she has the question there. I'll read it out loud.
Okay, I'm going to go ahead and pass it over to Dr. Desai. Thank you.
This question is from Anne and Richard. Have you noticed that many kids with ADHD or ADD, and also some on the spectrum, have auditory processing disorder? We have had to send kids to specialists or specialist audiologists who can diagnose and treat this.
Hello again. Thank you for the question. So yes, I have encountered kids with ADHD and with comorbid autism spectrum disorder, with or without autism spectrum disorder, who have auditory processing disorder diagnosis. And usually it's an assessment that's done independent of the ADHD assessment or autism spectrum assessment, sometimes through school or sometimes through independent agencies. And once the diagnosis is made, they are referred to counselors or therapists who can work with them to help with the auditory processing disorder deficits. However, this, if it's a comorbidity along with ADHD or autism diagnosis, then it should be the counseling or therapy should be in addition to ADHD treatment and autism spectrum treatment with medications and therapy or counseling as the need be. I hope I answered your question. And I didn't have time to cover the last slide, which I thought might be important to note. I had a lot of material to cover, so I had to really rush through my presentation. So I just wanted to take a couple of minutes to talk about adult onset ADHD. So in recent years, there has been a lot of discussion and controversy. Is adult onset ADHD really a diagnosis? Is it a reality or is it a myth? Now, many studies have shown that adult ADHD always preceded by childhood onset of symptoms. ADHD in childhood and adulthood share polygenic risk. Multifactorial etiological view of ADHD suggests ADHD is a disorder with continuum of ages of onset, with some subjects starting earlier than the others. The symptoms and impairment may emerge due to accumulation of environmental and genetic risk factors, as I've talked in my initial slides. And because of all of these factors, many individuals may present with ADHD symptoms at different ages, and you may not necessarily hear your patient talk about symptom onset before age 12. And that is something we all as clinicians might encounter in our practice, that when we try to diagnose and look at the criteria, it's symptoms, at least few symptoms should be before age 12, which often gets challenging, and I'm sure all of you, including me, have encountered this issue. And one of the reason besides adult onset ADHD concern is the onset of ADHD symptoms and onset of associated impairment can be separated by many years. And one reason which has been backed up and which I commonly see in my practice is higher functioning, higher IQ individuals overcome their deficits at younger age when the academics are not very challenging, as well as they have a supportive environment like parents, teachers helping out. So they do not see the deficits, they do not see the impairment significantly until later on in high school or in college, or when they are in their job, when the deficits and symptoms start surfacing, and that's when they come to your office saying that, hey, I need help. So something, some points that you might have encountered in your practice, I just wanted to share with you all. Thank you very much, and hope the presentation was helpful.
Dr. Desai, we have another question here.
Have you found any help sending people to occupational therapy who know how to do sensory integration? Yes, definitely sending for occupational therapy helps. Now, occupational sensory deficits are not part of ADHD, but often can be a comorbidity, especially as I mentioned that ADHD is highly comorbid with autism spectrum disorder. And in autism spectrum disorder, we know that sensory deficits are very common. Sometimes we also see sensory integration disorder as an independent diagnosis, irrespective of independent of someone with autism spectrum disorder. So if a patient I see in my office does have sensory deficits with or without other symptoms of autism, irrespective of whether I diagnose the patient with autism or not, I would refer them to an occupational therapist for an assessment and to get the occupational therapy initiated for the patient, and they very much benefit from that. Many times these additional help are available at schools. Many schools are able to offer OT assessment as well as therapy. Sometimes they have to go for independent assessment and outpatient provider for OT therapy. And I do have many patients who go for that and really benefit from that. Thank you.
Thank you, Dr. Desai. We're getting a lot of requests for copies of the slides, and when we post the slideshow and the presentation online. So what we're actually going to be doing is sending you guys the PowerPoint for everyone who has attended and provided their email address in the chat box. We'll provide you the PowerPoint by email, and then we'll also be adding it to our YouTube channel. We have a YouTube channel and posting it on our social media platforms. So we invite you guys to join or to follow our social media platforms. We have an Instagram, a Facebook as well, and a YouTube channel, which we post all of our CME and CE events. So we have about 5 more minutes. So you guys can actually use this time to complete your evaluation forms that I attached to the email that I sent to you. I'll leave the instructions here up on the screen for you. So you just make sure to complete your evaluation form. Email the completed form to my email address, anlo@siyanclinical.com, and then I will return a certificate of completion back to you. So that's how that will go. And then if you have any questions or have any trouble completing the evaluation form, feel free to reach out. My contact information is in the email that I had sent you. Other than that, have a great evening. Thank you all for joining, and we hope to see you at our next event.